As Dr. Nick Merrifield said, my name's Harriet. I'm a clinical pharmacist and I'm an independent prescriber in hormone replacement therapy. So I hold specialist HRT clinics at the surgery that I work in New Malden. So I hope everyone can see my slides and they're up okay. So what I will be going through today is just some ways that we can help with the menopausal symptoms. So lifestyle changes, hormone replacement therapy, who can take it, what we go for and why, and how we monitor and review this. Okay, so first of all, I've got some pictures here just to prompt some thoughts on the changes that we can make in terms of lifestyle changes. So just to go through a few of them. So we've got some clothing choices up there. So just making sure to wear things like breathable fabrics, natural fabrics that can wick that sweat away when that does happen. So cottons, linens, bamboo, and layering, which can help with temperature regulation. So taking those layers on and off as needed. We've got some alcohol options on there. So we know that alcohol can have an effect on our mood. It can cause us to be more anxious and it can actually cause hot flushes to be worse. So looking at reducing alcohol intake can really help to reduce the symptoms that we suffer with. Looking at caffeinated drinks in a similar way, caffeine can have an effect on our hot sweats, anxiety, and our sleep. So reducing that can help with all of those symptoms that overlap. Now, exercise, I've got a couple of options up there. So things like weight-bearing exercises, that can help to strengthen our bones, that supports our mental health and helps with weight management. And then we've got things like yoga, and that includes things like mindfulness, which can help improve our mood, reduce stress, and it can actually help with hot flushes. And also exercise in general can help with our sleep. Now, talking about sleep, I've got a bed on there. So in our bedroom, we have the authority to manage the temperature that we're sleeping in, making sure we're using a lightweight duvet to help with those hot sweats overnight and therefore helping with the sleep, and having a good bedtime routine can help improve our sleep as well. Now, smoking, women who smoke may experience menopause earlier and they may suffer with more severe symptoms and actually may not respond to some of the hormone replacement therapy options available as well as if they weren't smoking. So it's always a good thing to look at generally, but more specifically with menopause as well. And then the last one on there is having a balanced diet. So ensuring that you're getting a good balance of food in there. So fiber, protein, making sure our calcium intake as well, and not necessarily having any restrictions, but just supporting our overall health. So in terms of hormone replacement therapy, and thinking about who can and can't take it, is it suitable for me, or because I've got certain conditions, can I be using HRT? So the thing is with HRT, it isn't a one size fits all, and there should always be an individual discussion around this with a healthcare professional. But generally, those with a history of estrogen-related cancer may not be eligible for hormone replacement therapy, as it can stimulate these cancers to grow. So Anna will be covering a few more details in terms of who can't be using HRT, but it's always worth consulting a healthcare professional because there are lots of things that can be done to help you be more eligible for HRT and other options if actual hormones aren't suitable. So looking at benefits of hormone replacement therapy. So really the only reason we're using hormone replacement therapy is to help with the symptoms that women suffer with. So we're looking at the benefits being relieving those symptoms, which helps to improve the quality of life. I have lots of women that I speak to that say that change their life and makes them feel like who they used to be because they lost themselves through the menopause. Now, there's also the positive that it can help to protect the bones and keep the bones stronger for longer with that estrogen getting back into our system. Now, with the benefits, we have to weigh up the risks as well. So there are some risks associated with HRT, and generally that's a slight increased risk of breast cancer. It's said that HRT doesn't cause cancer to occur, but if you have any cancerous cells present that are already hormone sensitive, the HRT can cause them to grow at a faster rate. There are also other risks, such as an increased risk of blood clots. This happens with specific types of HRT, and I'll go through that in a moment. And there's also a slight increased risk of endometrial cancer. That's just the effects of estrogen on the body, which I'll also cover as well. Now, just on that first note, looking at the risks of breast cancer, I always like to show this, which is showing the incidence of breast cancer per 1,000 women aged 50 to 59 years in the next 5 years. So on the slide, you can see that in general, there's 23 cases per 1,000 women, but there are lots of ways in which the breast cancer risk can be increased, which is good to know the comparison there, because saying that there's an increased risk, it's hard to determine what that risk is for you and your decision on that. So seeing in here that actually having a BMI equal or greater to 30, that can nearly double your risk. Whereas with HRT, is often that it's just 4 cases per 1,000 women. And I really like on there that 7 fewer cases in women who take at least 2.5 hours of exercise per week. Okay, so how do we take HRT? So as I said, there are a few different options available on how to get the HRT into your system, which I've got a few examples actually here with me. So there are gels available, which come in a little bottle with a pump pack, and that's just then squeezed out, not necessarily onto your hand, but normally applied onto the legs and rubbed in. You've got things like sachets where there's also a gel in, which you can see is probably a bit less quantity in there. There are things like sprays, which are available, which you spray normally onto the arm, and that goes into the body through our skin, which is generally the safest way for estrogen to be taken because it doesn't have that increased risk of blood clots. The other options are things like tablets, okay, which unfortunately do have that increased risk of blood clots, but that can all be discussed in an individual conversation with a healthcare professional. I've also got a Mirena coil on there because that can be part of the HRT as well, which I'll cover in the next couple of slides on how that is the case. Okay, so I always like to have a picture of the menstrual cycle up. So it's just showing over 28 days what happens in a natural menstrual cycle. So it looks a bit confusing, but what I tend to say is the top one is to do with the brain, and that's telling our ovaries what to do, which is the second part, which is, you know, the follicle, which is the egg and the sac being matured and released, and the sac then shrinking, and that's what produces our hormones. So that's where the estrogen comes from. And as it's just been explained, we're losing the estrogen, which is causing all of our symptoms. But one thing estrogen also does is it thickens the lining of our uterus, which this is all for the possibility of a pregnancy. So with that, if we're giving you estrogen, we're worried that we're going to thicken the lining of your uterus, and then we're worried that your body's not going to get rid of it. So naturally what happens is we have progesterone come up, which you can see in the second part there where the progesterone rises. Now, when the body knows there's no pregnancy, the progesterone drops, and that's what tells our body to get rid of that lining, and that's where our period comes from. So if we're not having this cycle happen, or it may not be happening as we expect it to, we're worried that we'll be giving you estrogen, thickening the lining, and the lining staying there for too long. And any cells that hang around for too long always have the chance of mutating, and any mutations can end with cancerous cells down the road, which obviously that's where the risk of endometrial cancer comes in. So then looking at how we reduce that risk is we would give you some progesterone alongside the estrogen to help reduce that risk. And we do that in different ways depending on if you are perimenopausal, so before the menopause, and still having menstrual cycles, or postmenopausal and not having any menstrual cycles. Which I think it also comes in, there's a question about having an Nexplanon, can that cause issues or confusion in menopause transition, which probably answer after this, but it can confuse things with knowing if you've gone through the menopause and you're postmenopausal or not, but that can also come into what treatment options are suitable for you. But generally, what choice do I go with? In terms of estrogen and progesterone, if you've had a hysterectomy and no longer have a uterus, you don't need any progesterone to protect the uterus and reduce the risk of uterine cancer. So it would give you estrogen only, and that can be titrated to help with symptom control. If you do have a uterus present, as I said, it depends on being perimenopausal or postmenopausal, where we give you the progesterone in different ways to help make sure we're protecting the uterus and reducing that risk of endometrial cancer, although we can't say that we're getting that risk down to zero. And then the choice between which different options you go for really depends on your personal choice and what fits in with you and your lifestyle. Because things like the gels, they're applied every day, tablets are taken every day, and the sprays every day. I've just realized I missed talking about the patches in a few slides earlier, but the patches, they're applied twice a week. So some women find that easier to deal with and not having to do something every day. And then in terms of monitoring and reviewing, so this is different for different clinicians, but generally it's recommended to trial hormone replacement therapy for up to 3 months initially to see how you get on with it and how you respond to it. Depending on the response, we can titrate and manage any problems and see if there are any problems, what options we have and what we can do to improve those. Or if everything is well covered, then we can continue, and we tend to review once a year after that. But obviously, if there's any problems in the meantime, things can be dealt with at any point by contacting the doctor's surgery and having that review. And then the last couple of bits I wanted to cover is that HRT, it isn't a contraceptive. So we would recommend a contraception alongside the HRT. Now that also depends on if you are postmenopausal or perimenopausal. If you're postmenopausal, it depends on how long it's been that you haven't had periods. And perimenopausal would recommend to have the contraception up until the age of 55. There's also a prepayment certificate, which is available to cover prescription charges. So you pay 2 prescription charges or the equivalent of for a certificate, and it covers your HRT prescriptions for a whole year. Okay, so I know that was a bit of a quick whistle tour of hormone replacement therapy, but obviously with the time limitations, so we can really cover. But obviously with appointments with healthcare professionals, they can go deep delve into you as an individual and make sure you're getting the right thing.